Manish, Ragini. Dogra sir, come on the dais. Manish, come on the dais. Dogra sir, come on the dais. Kuresh sir, BK sir, Lalit Verma sir, Rashmin Gandhi. Please come sir. Come on the dais. So this is the session which deals with day-to-day problems, and in that what we will do, how we will solve those issues. That is the session, and in that I welcome the Dogra sir, Rashmin sir, then the Parikshit, Manish, and Ragini. So myself, Dr. Lahane, and now I will request Sheetal. कोणी आहे का pediatrics? Pediatrics कोण आहे पण आपल्याकडे? To present a case of squint and neuroophthalmology. Dr. Sheetal, Rashmin आहे. Sheetal.
Rashmin bhai is there.
She will present us squint and neuroophthalmology. Dr. Sheetal. Sheetal works with me and she is a wife of Dr. Sumit. Go ahead, Sheetal. Rashmin sir, that is your case. Yes.
Good evening, everyone. Today I'll be presenting a case on neuroophthalmology. A 10-year-old male child brought by parents with complaint of headache and decrease in vision since last 6 months, more since last 3 months. That was right eye more than left eye. So they consulted locally, and child was diagnosed of having myopia, and he was prescribed glasses. That was around -5 sphere in right eye and -4.5 sphere in the left eye. Still, headache was not getting resolved, so he consulted elsewhere. This is the fundus photograph which he carried along with him, so which was suggestive of bilateral disc edema, and along with that, we can see exudates at the macula, that is macular star, and patient was diagnosed of having neuroretinitis, and he underwent investigations for the same. So Bartonella IgG and IgM were negative. VDRL was negative. Chest X-ray within normal limit. Montux was negative. Still, patient was advised oral steroid. He completed course of oral steroid, but headache was persistent. And there was non-resolving disc edema along with macular star. So they suspected idiopathic intracranial hypertension. MRI was advised. MRI was within normal limit, and then ophthalmologist advised him lumbar puncture. At that point, patient came to us for second opinion. These are the examination findings. Right eye best corrected visual acuity was 6/18 and 10 with -5 sphere, and left eye was 6/9 and 6, not improving further than that. Rest anterior segment was normal. Pupil, both eyes sluggish reacting to light, no RAPD. Fundus was suggestive of disc edema with multiple exudates around the macula, suggesting macular star. This is the fundus photograph. I'm really sorry for the glare. In this picture, we can see blurred disc margin, though macular star is not clearly visible, but it was there. This is the OCT disc picture, which was suggestive of disc edema. And macular OCT suggestive of macular edema along with the exudate. I'd like to ask the panelist, what will you do in this case? Would you advise repeat MRI? Would you advise some other investigations, like do you want to rule out a typical optic neuritis or something like that? And is lumbar puncture necessary in this patient?
Ashwin sir?
Yeah, so I think there are few things from the history point of view that you will consider. You have a long history of 6 months with 3 months of continuous progressive loss of vision.
Yes.
So confusion, of course, here is that are we dealing with inflammation, which is neuroretinitis, or are we dealing with something else?
Yes.
From the history perspective, neuroretinitis generally would not behave this way, or any optic neuritis would not behave this way.
Yes.
There is an inflammation. There are two possibilities. With your treatment or without your treatment, inflammation will subside, patient will improve.
Yes.
With your treatment or without your treatment, inflammation will continue, will attack the neuronal cells, there will be axonal death, patient will optic atrophy. And generally this process completes within 6 weeks to 2 months. Now what you have is a 6-month history with a 3-month, following 3-month thing is where even the other person would have thought of lumbar puncture.
Yes.
And I would like to do lumbar puncture, whether it is IIH or not, we don't know right now.
Yes, sir.
The factors pointing towards increased intracranial pressure is persistent headache and non-resolution of disc edema. There is nothing happened to disc edema. Those steroids also was given, right?
Yes, oral steroids were given.
Yeah, but
Yes,
I mean,
it was
with
given.
some treatment, by 2 months, I would have expected this disc to become normal. So we now are looking for some other cause.
Okay.
So is it hypertensive retinopathy, though there are no other features, or is it raised ICP is what we are looking for? So I would have thought on those lines and maybe ask for lumbar puncture because we don't know whether this is, and in fact, even if it's an atypical inflammation, lumbar puncture, the analysis of CSF will have.
Okay.
Dogra sir?
I think you did talk about the hypertension. Blood pressure has to be taken because sometime if there is a renal involvement, we might have a lot of exudation and situation may be because of the accelerated hypertension. And another thing which I would like to do before going for lumbar puncture is the fundus fluorescein angiography because that may give us additional information. Sometimes this kind of exudation I have also seen in cases of Irwan, which is very typically seen like that. So I think that can only be picked up once you do an angiogram because you will see those knots in the arterioles. Those are the aneurysms there. So these are the, in addition, before going on to, I would like to.
And the one more clue is that with all this history, vision is not too bad. It's not like 1 by 60, it's 2 by 60. It is still holding on.
Yes, 618.
Jagatram sir, please come on the dais. I think I think when such type of case comes to you, better to investigate, and investigation only can give us a clue. So that is very important. I think both you are correct. So
I'll go ahead.
Yes.
So in this patient, we just did, as almost all investigations were already done, we just thought of checking his BP, and BP came out to be 250 by 120 mm of Hg. And on detailed history, parents give history of frequent urinary tract infection. Patient was referred to pediatrician and nephrologist. There he was diagnosed of having chronic kidney disease stage 3, secondary to reflux nephropathy grade 5 and hypertensive emergency. He was, they repeated his MRI, which was suggestive of posterior reversible encephalopathy syndrome. MR angiography was normal. Patient was admitted for 15 days. There he was started on treatment, and patient reviewed back after 1 month. That time he was symptomatically better, though vision was same, like right eye was 618, left eye was 69. This is the fundus photograph in which we can clearly see disc edema is now resolving, and we can clearly see macular star. OCT disc also confirmed the same. This is the 6-month follow-up of the same patient. Here we can see pallor is clearly set in and resolving resolved macular scar, almost resolved macular scar. BCVA of both eye is almost 612 by N6. Now there is no headache, and BP is well controlled, that is 100 by 78 mm of Hg. This is the OCT disc, which definitely suggests now RNFL thinning because of pallor. Normal OCT.
Go behind. Now Manish, disc. Now Manish, my another question is, when you get the OCT, now what has happened when there is a glaucoma or anything, we go for OCT. And when there is a problem of the optic nerve, there also you get the changes in the OCT. And once the changes are in the OCT, then the general ophthalmologist can think this is a glaucoma, they start the glaucoma treatment. Now, how to differentiate OCT of the optic nerve disease and OCT of the glaucoma?
So that's a very, very important point, sir, that you have pointed out, because now you have worked up all this patient, Sheetal has worked up, and now this patient comes to me for a second opinion that because of some ophthalmologist sees the optic disc pallor and does the OCT, which shows thinning of the nerve fiber layer in both the sides. And if you see that it's following typical glaucoma picture, so you will definitely point this disc as an abnormal disc. Then obviously when we do all the tests, first of all, if a child of 10 years comes with this kind of a picture, and if I check the pressure and it is normal, first and foremost, there isn't any great reports of normal tension glaucoma in children. So pediatric normal tension glaucoma is not a very established entity at all. So first I would not think of that. And if this is patient has just come, no history available, then I would investigate neurologically only for this patient. And second, supposing this patient somebody comes with similar picture who is in the older age group where normal tension glaucoma can occur. So definitely we will do fields. You have to watch. Glaucoma means is something you have to all the time look back and watch. Means you cannot ever be sure that this is not glaucoma. So I would say that all these cases which are on the border of optic disc appearance are what we call pre-perimetric glaucoma or normal tension glaucoma pictures. Unless they are threatening fixation, we don't immediately label as glaucoma and start treatment. We put them as glaucoma suspects. And there are a large number of patients who fall in this category. And you have to explain to the patient that this can be a thing which is not going to cause a problem, but it can be. So we need to know which category you are falling in. For that, you are going to come for tests to me and see me again and again. Of course, at the baseline, you have to do the full workup because you cannot be sure that this is not glaucoma. But in this case, 10 years age, I would not be that particularly concerned, especially if IOP is normal.
Dr. Manish, can I ask one question?
Yes.
So, would you consider some features on OCT as a telltale mark or maybe suggestive towards more glaucoma?
So there is the ganglion cell layer. If somebody was attending the last talk in the last lecture, session here, that person who failed to mention that one very important sign which is there on OCT, on ganglion cell analysis, and that is the horizontal line. When you get the ganglion cell analysis and you see a horizontal line which is extending to more than half the length of that analyzed area, so that is basically indicating the horizontal separation of nerve fibers which exists and which is the telltale sign in glaucoma. So if you see that, then that is a very good sign for you to, think that this damage is occurring with the ganglion cells and the nerve fibers are getting affected before the disc got affected. Because this patient has this defect, but this has originated from the disc. So it's not going to follow exactly that pattern. But that test has not been done and we don't have that data in this case at least.
Yeah, and I think from the neurological perspective, especially like somebody who has a pituitary tumor where OCT has a role to play, you will have a very clear binasal, prepondering binasal involvement corresponding to bitemporal hemianopia.
Take-home messages. Eyes are not only for the vision, they are the windows to your health. Thank you.
Thank you, Sheetal. I think what expert says is very true, that OCT, once you are doing OCT, in that, if there are changes in the OCT, yes, it is if it is like a pediatric child with a normal tension, then in such cases we can say no. But in the other situation, you will have to do perimetry investigations, and after everything, again we will have to do follow-up. Because without follow-up, then what happens? Then if there is a glaucoma, it progresses so far, and then there is a problem in the vision. So it's always better to follow the patient when it is such type of finding is there. Thank you. Thank you very much. And now I will call upon Dr. Wankhede, who is going to speak about the cataract case. Manish. And Jagatram sir is there, Ragini is there. Also the Parikshit is there. Yes, go ahead.
Thank you very much for this golden opportunity to present in front of all these stalwarts. Today I will present a simple few cases of cataract surgery which we on day-to-day life we practice, and this was a simple dense cataract. Everything was going on normal. I do the Rexis, dense NS3 cataract, normal direct chop technique, and there was nothing in my mind until this step. Even we can see when I put the viscoelastics, the AC was very well formed. I started my bimanual irrigation aspiration. Happy, and then again suddenly the problem start at this step. When I change the hands for bimanual, I see the PC is bulging upward, anterior chamber is getting shallower and shallower. I was thinking, what is this? I try to form the AC by placing the viscoelastics. I start to push the viscoelastic by side port. I remove the speculum, but the PC started to bulge continuously. Then I again put some thicker viscoelastics like cohesive viscoelastic, change the speculum, and thinking what next. At this point, I put more cohesive viscoelastic and try to buy some time. Now my question is how to proceed further.
Now the Jagatram sir.
I think you did very well. Capsular Rexis was excellent. And maybe I think it was in a fast forward mode video,
yes,
but
yes.
it appeared that you did a very, very fast cataract surgery. And while there was I think probably I could not see, I was signing while that point came that whether there was a PCR or not. You removed the cortex also very well.
Yes, sir.
So now we have to see whether there is a PCR, what is the extent of the PCR, and what should be done, whether we can implant the IOL into capsular bag, or whether 3-piece IOL is required or single-piece IOL. That we have to decide.
Ragini.
So basically, I think that the capsular bulge is there. What you have done is correct by changing the speculum, which was causing the pressure. And there is no iris prolapse or anything. Now, your problem is how to insert the IOL without causing a PC rent.
Yes, ma'am.
So you have to see there are what you're using is correct, the cohesive viscoelastic, and to put in the IOL. I think you can go ahead and put in the IOL because the AC is formed right now and the bag is also inflated.
I will ask Dogra sir.
I think retina persons, they think something different. So it could be if something is happening behind, why it is getting so firm and shallow. So I think better to have a look behind and rule out the serious thing before you plan that. Because sometimes there could be hemorrhagic choroidals happening and maybe limited, but then that is what can cause. So, but that is just that being a retina person, we see these things, and I thought I'll just mention it.
If it is there,
Yeah.
what treatment you will add?
Then I would advise to close the eye at this time, because otherwise it's going to be becoming total and kissing, which is a problem. If it is limited, it will go away of its own and you can implant the lens later. Because the closing eye fastest is the best way. That is what happens.
Parikshit.
One is, as cataract surgeons, so we want to think of the cataract, or that's how our brains work. So if possible is to put in a lens quickly and just be done with it and come out, because the surgery has been done well, there is no rent, the CCC is also perfect. So putting in a one-piece IOL shouldn't take more than about 30 to 60 seconds. But if you think that the bulging is too much, then as Sir says, if we have taken an IV access, we can perhaps give IV mannitol on table. That will make the vitreous less turgid and make it faster. But if the bulge just keeps on happening, then the best is just to close it, let it be, and then give mannitol later, because that will still be needed outside the theater, and perhaps do the implant a couple of days later.
Sir,
Basically, when it is getting very much shallower, I have seen that is coming. Like there may be a concealed, you can say there may be a concealed hemorrhage type thing may be there. Or if you are now putting the lens and if there is no space, then also you can tear the PC. One thing what they said is, okay, close the eye, get the pressure control, then you implant the lens. Secondly, you can just give mannitol. Or third thing, you can do the vitreous tap. On one side, you can do the vitreous tap behind. So once you do the vitreous tap, there will be hypotony, and this will help you again. Go ahead.
Sir, can we foresee in which cases we may get these kind of complications?
Can you?
Can we predict before the pre-operative procedure?
Now see, in that, was that a fast forward this hour? It was your speed.
No, it is a fast forward, sir. It is 4 times fast
Basically, what happens when you are doing the phacoemulsification slightly faster. So in that, what happens? The lens comes out and the vitreous bulges. It is because of, you can see the hypotony which is created in the anterior chamber, and that causes the bulge behind. So always better to go ahead gradually. Secondly, the wound leak. Your fluid was leaking from the phaco, you can say probe, where from you have entered. That was leaking there. So this wound leak can also cause an hypotonus, this one, and that gives rise to shallow anterior chamber. So to avoid, your wound should be proper, there should not be wound leak, and thirdly, you should go properly. Go ahead.
I completed the case by taking the vitreous tap with 26 gauge needle in infero-nasal quadrant. As soon as I took the tap, the AC was well formed, and it was possible for me to place the one-piece IOL in the bag. Many of the times, these situations also happened with me. I will like to share one more example. In a similar case, I placed the Blurex dye in the anterior chamber, and the whole of the dye was leaked in the vitreous cavity. Whole vitreous was changed into the blue vitreous, and I had to complete the case against the blue glow and up to this stage. And this was the final result. Maybe this is also can be set as an example of the fluid misdirection.
Aqueous misdirection.
Yes. About the second case you want?
Yes.
Yes, sir. Second case, there is a vitreous, can say, when he was stained, that time you can see vitreous in the anterior chamber. Now, how he should proceed now?
This is, you have not still done phacoemulsification. Nothing has been done. I think it is best we inject triamcinolone and do the vitrectomy, whatever vitreous bulge is there, and then we can stain the anterior capsule, do continuous curvilinear capsulorhexis, and depending upon how much dehiscence is there, you can apply even a capsular hook to the capsulorhexis margin to make it secure and firm, that you will be able to do complete phacoemulsification. So I will go like that.
Same, sir. First is to see that whatever is the vitreous that has come in the front is first dealt with, then do a cataract.
You want to add anything?
No, same, sir. There was one point. I think just one point what you asked as to what cases we will probably suspect or would be more vary would be somebody who has a very small eye is where you suspect, because thick sclera, that they can end up with the problems which Dr. Dogra mentioned.
Now, this is the vitreous in the
second case. This is the second case I want to present.
This is the
second case I want to say.
that is a vitreous in the anterior chamber, na?
No, sir. This is a different case.
This is that was a vitreous.
That was vitreous.
Now this was not vitreous. Okay, go ahead with the case.
Sir, this is another case. In this patient, I have done the pterygium excision and went ahead with the routine cataract surgery. Everything seems to be fine. All the steps were done and all went very smoothly. I have shared few details that even the hydro dissection was complete. It was possible for me to do a complete nucleus rotation, and the whole of the emulsification procedure was smooth and seems to be uneventful for me. Everything went very smoothly until I removed the last piece of the cataract. And as soon as I removed the last piece, I noticed there is a small PC rent just in front of the picoprobe, and the liquefied cortex was going in the vitreous cavity from that part. I was confused that it is a PC rent or it is just a punched out PC rent, because as soon as I withdraw suddenly, the whole of the cortex which was in the vitreous comes slowly in front and the rent didn't enlarge. So to my surprise, it was unusual to have a PC rent and it is not getting enlarged even after doing so many mistakes. Sir, this is my question. Did it was a pre-existing PC rent or it happened during punch out?
Jagatram sir?
I think we must see what is the size of the posterior capsular rent, whether it is a pre-existing or it is done during surgery, and then whether we can implant a single piece IOL or 3-piece IOL.
Yes.
And of course, I think vitrectomy will be required for the vitreous bulge or whatever PCR. It should be made free from vitreous.
If it was an old rent, then perhaps there would be some calcification around the rent to make us show. If it's a fresh rent, that won't be the case. But whatever it is, a vitrectomy will have to be done.
See, the very fact that there is the cortex in the vitreous is that there is a PC which has been compromised. Sometimes, through the periphery also without the PC compromise, you find small particles of cortex in the vitreous, which you can see hanging around. But here, there is a large chunk of cortex. So definitely somewhere the PC has been compromised. One has to wait and not to do any anterior segment manipulations unless you do a vitrectomy, or to do a posterior segment vitrectomy to clear this cortex and then go ahead, which is very, very important. Whether it was present earlier, I don't think so, because like Parikshit Bhai, I would think that there would be calcification and fibrosis around it. Manish?
Was it present before? See, what happens if there is a PCTL, like we get in the posterior polar cataract. So normally this type of PCTL you see in the center, not on one side. Secondly, this type of PCTL, when you see, this is an oblong type of PCTL, not circular type of PCTL. Secondly, if it is an old PCTL, so that PCTL you will get so much of the calcification and fibrosis. Because what you feel is why it is not increasing. So what happens sometimes, if your cortex has gone behind and patient is not having much of the hypertension, or you can say the intraocular pressure is not more, so sometimes vitreous will not come up. So that is a hypotony. Because of this hypotony, vitreous will remain there. And if vitreous is not coming forward, then the tear will not get increased. So that happens in few cases. You are operating under peribulbar or topical?
Sir, this case was under peribulbar block.
It is normally happens in the peribulbar. You get the hypotony, and because of hypotony, the vitreous doesn't come out. But yes, this is a PCTL, and it is happened because of the, you can say, your aspiration or whatever the trauma it is. And this is a PCTL. So you can do vitrectomy and then implant the, which IOL you have implanted, 1 piece or 3 piece?
Foldable 3-piece.
Foldable 3-piece. It is always better to implant foldable 3-piece, and you can have an optic capture also if you can do it. Okay. Thank you. Thank you, Vankade. Thank you very much. Now this glaucoma case we are taking. Sachin is there? So you are presenting. Dr. Sumit, presenting the glaucoma case. Dr. Sumit Lahane. my son, who makes our all presentations, we present only. So from 2016, I have not made a single presentation. Mahipal sir, so I have not made a single presentation. So whatever the presentation is made, but by him. So if I will call this, मैं बुलाता हूँ, एक चेयर लेके आओ नीचे से, एक चेयर लेके आओ, चेयर, हाँ है ना, आइए महिपाल सर. Okay, go ahead.
Very good evening, everyone. I need to start from case 4. Can I take the control, please, here? Audio visual. वहाँ से कंट्रोल ले रहा है, ठीक है, उनको बोलो कुछ. I would like to thank Dr. Maya, our friend and colleague, for this case. It's a case of a 37-year-old male who came with the complaints of the mild blurring of the vision and the headache since 10 days. There is no redness, photophobia, or any such previous episode, no history of glaucoma, no trauma, no steroids or any systemic medication. Patient had a vision of 6.6 in the right and the 6.9 in the left. And the anterior segment examination of the left eye showed cells and the flare congestion, and the pressure in the left eye was 40 millimeters of mercury, while in the right it was only 10. Angles were open, discs were healthy, and we considered the diagnosis of the uveitic glaucoma with or without trabeculitis. Patient was started on the steroids with cycloplegics. Also acetazolamide and the combination of brimonidine plus timolol. That reduced the pressure to 21 millimeter of mercury. After a week, after acetazolamide was stopped, pressure again increased to 40 millimeter of mercury. Again, anti-glaucoma were added and acetazolamide started. His CCT was also normal. This is the disc picture. And these are visual field which almost appear normal. And the OCT disc as well. Patient was kept on the follow-up. Pressure was constantly in the range of 30 to 40 millimeter of mercury, and he was on acetazolamide on and off. After 3 months, his pressure was still high, so prostaglandin analog was started. And after the max AGM, still the pressure is in 30 millimeter of mercury. This is at the end of the 3 months of the treatment. Now the visual field in the left eye has started showing changes. OCT started showing changes. And in this young patient, what do we do? Since we consider primary diagnosis of inflammatory glaucoma, is it juvenile glaucoma that we missed out? Is there any role of antivirals? Now there is a disc damage, so what are the treatment options? And do we operate him with or without steroid cover, or directly go ahead with the MIGS? Manish.
So definitely the initial presentation was a uveitic glaucoma and probably of viral origin, and it could be the amount of cells was reported to be a very low amount of cells. So there is something called as acute depigmentation of iris, which can be associated with high pressure. You get transillumination defects. That has not been studied, where it means it's not been reported in or observed.
In this case, yeah.
And sometimes they are associated with high pressure. Usually you treat, and it can resolve and come back. The iris pigments disappear, and the pressures goes down when the iris pigments disappear. In this case, iris pigments, or the flare went away very quickly with steroid treatment, but the IOP refused to get controlled. And eventually, we are observing disc and field changes appearing too. Now, the role of antivirals would be there in cases where the uveitis would be active. So if the uveitis was difficult to control, and we could probably give antivirals. But here in this case, the uveitis went away almost in 1 week only. So I would not give antivirals just empirically. Antivirals also work best when given when the uveitis is active, when the virus is not in a dormant stage. So then you can give antivirals. Otherwise, he was treated with steroids and steroids were withdrawn. You have to consider steroid response. But when steroids were withdrawn, the pressure still didn't come down. So this is not a case of steroid response either. And for some reason, the pressure is not coming down. Now, once you have exhausted the options of medical treatment and pressures are in 30s, that is, and disc field changes are developing, you can't leave this patient, you will have to opt for surgery. Now, whether the surgery should be trabeculectomy or whether it should be a valve implant or it should be a MIGS surgery. So basically, I would not definitely go for a valve implant directly in this case because the uveitis is not very active, so there's not that much chance of fibrosis. So I would either opt for a trabeculectomy or an MIGS. I think it is if the angles he has reported are completely open, I think, and the disc and field changes are mild. So it is out of the box. Actually, MIGS is not recommended in this subgroup of patients. But to save the conjunctiva and have the better future, if you need, you can do trabeculectomy. I would probably give a trial of an MIGS. Which MIGS I would do? I would prefer either a KDB or a GAT. But I am not very happy with GAT in my personal hands, so I would probably go for a KDB or a needle goniotomy if financial factors are playing a role.
Rashmin sir wanted to add something.
Yeah, I just wanted to ask, since there was a possibility the patient had uveitis, would you have started on prostaglandin analog? Because
so the person has reported very clearly that for 3 months, almost after the uveitis appeared, or almost 2 months after the uveitis appeared, he didn't give prostaglandins. And in uveitic glaucoma, if after the uveitis has resolved and you have observed for a good amount of time it's not active, you can give prostaglandins. But very important is when you give prostaglandins, you need to observe very closely, because I have had this personal experience. You give prostaglandins and within a week you get uveitis back, even after 2 months gap. So if you can observe, and the best thing is once you get the uveitis back, the pressure goes down. So if you just see pressure, you will miss the uveitis. So uveitis can come back, especially viral uveitis, known to recur with prostaglandin analogs. So if you are giving prostaglandin analogs, you have to be very watchful. Now you have the option of the ROCK2 inhibitors, which have reports of being suppressing uveitis. So before giving prostaglandin analog, after trying the timolol and all the standard things, my first choice would be to ROCK2 inhibitor before prostaglandin analog.
Sir, yes.
Won't TRAB with steroid cover also be a good option?
Very good option. That's the only reason I said MIGS, because the patient is young and it is like just a trial. I would not, it is out of the box, it is not recommended in this kind of scenario. So MIGS, the people all over the literature suggests MIGS is best done for primary open-angle glaucoma of a mild or maximum or moderate variety, and which is well controlled on medications. It is not a good operation to do on patients whose pressures are very high. So this does not fit in the standard parameters. So if you want to go by very conventional, strict thinking, trabeculectomy under steroid cover would be the right thing to do. But now, we are willing to compromise a little, especially take the patients. There's no flip side. It's not in the ideal category, so it is likely not to work. But if it works and you get a little response, you get away from, putting a permanent fistula in the eye.
One question out of the context to Manish sir and the Rashmin sir both. So generally we give acetazolamide for a very short time because we are worried about the adverse effects. So in your experience, how long have you given patient on acetazolamide, sir? You for IIH cases maybe and you for glaucoma. How chronically have you kept patient on the acetazolamide?
For IIH, can go up to 6 months or even more. And sometimes in refractory IIH, you can go up to 2 grams if these patients, if they can tolerate. So such high doses can go on for 2 months or so. And then the treatment may have to be continued for 6 months or so. But of course, at that dose, a lot of compliance issues will be there.
So basically, the use of Diamox in patients, it's the full dose, as he mentioned. If you are going to give 2 grams or you are going to give 250 milligrams 3 times or 4 times a day, that is going to cause a lot of side effects in the form of the acidosis, and it can, so a lot of neurological, those burning sensation and tingling sensation, all that. But if you use a very low dose, surprisingly in patients who are already on maximal numerical therapy, and you're just toying the idea of whether, and especially if they have got problems which you cannot take for surgery immediately, give half a Diamox also sometimes has an effect, and it's very well tolerated, and giving it for a long time also seems to be quite all right. It doesn't seem to cause a problem. And patients for this kind of scenario, if you see neurological cases besides just hypertension, there people are giving just like patients who have had intracranial hypertension, which is secondary to other things like tuberculosis, meningitis, and things like that. People are giving Diamox for, I have seen for a year Diamox continued, and patients are able to take. The dose can vary. So we are sometimes can use Diamox, but you have to see how it works. It's not a standard recommendation.
I think in neurological cases, they are giving 1 year Diamox, they are giving. But Rasmin and Manish, day before, I think 3-4 days, I have operated one case, right eye traumatic cataract. He was a MLA. When he came to me in 2014, and that time his pressure in the eye was more than 56. So that time I have started him the IOPAR SR, BD, and then I have given him the, I think the Bidin tea and this one, I think the Travaprast, both. And then I told him, okay, we will operate once the pressure comes down. You come after 7 days. He came to me after 9 years. And 9 years, he's a MLA, big man. 9 years he was taking the IOPAR SR, and he was saying कि मैं गोली नहीं लेता हूँ. If I will not take this medicine, there is so much of the pain. For 9 years. So just now I have operated him. He's a traumatic cataract. Just now I have tackled after the 9 years of the IOPAR SR. So I think he was not having any problem with that IOPAR SR. But this is first case in my life who has taken the Diamox for 9 years. So I don't know what are the side effects in his body, but he has taken it.
Should I go on with one more case, or Zain has a refractive and cataract case? Okay, so I'll just quickly finish one more glaucoma case. Again, this is by Mayao sir. A 55-year-old male reported to OPD with the complaints of diminution of vision since 1 year. There was an episode of redness pain in the right eye 2 years back, and he is a known diabetic, not well controlled. Vision is 612/66. Anterior segment, there are few pigments on the endothelium and the anterior lens. Left eye is normal. Right eye fundus shows floaters with 0.7 CDR with the bipolar rim thinning. And there are no signs of diabetic retinopathy. Minimal exudates in the periphery, could be pars planitis. Left eye fundus is normal. Pressure in the right eye is 44, left eye is 18, and it's open angle. And this is what we see, if the picture is clear. On the superotemporal quadrant, you can see the subtenous deposit of a depot, maybe, or steroid. Considering the size of the deposit, is it conservative treatment possible, or the removal of the triamcinolone deposit should be done? Is there any role of surgery with the depot removal together, or do only a surgery?
So definitely you have identified that it is a steroid-induced glaucoma, other eye is totally normal, and it is the triamcinolone depot which has been given, which is responsible for it. And you have given maximal medical therapy, and pressure is 44, not showing any response to medical therapy. And there is disc damage already occurring. So there is no question over here. You have to get that pressure down, otherwise there will be serious consequences. So in this situation, the depot steroid was given how many? 3 months ago?
Yeah.
3 months back. So I have, in my experience, seen patients like this where we have operated and removed that depot steroid, and observe the patient for a short time, just a depot steroid removal, and observe for some time. Usually the pressure starts coming down, and if everything settles, then you can maintain on some anti-glaucoma medication if required. But if pressure settles very well, you need not do a trabeculectomy. So I am not sure whether this patient will need a trabeculectomy or not, and I am not very much in favor of putting in a filtering fistula without being really sure. So I would definitely aim for removal of the triamcinolone, continue medical therapy, observe for some time. If pressures don't respond and ultimately a trab is required, then we can do a trab as a second sitting. I would not like to do a combined, though I have to explain to the patient very clearly that it may be required.
Stepwise approach.
Yeah.
Thank you, sir.
Dogra sir, you put the implant. Acha.
Zen.
ठीक. I think my question to Manish is that when there is you can say steroid-induced glaucoma, it is said that if you remove the steroid or stop it, it continues.
So there are two phases of the steroid-induced glaucoma. Yes. One is the stage when it reverses, and the other stage is when after some time, if it has been there for exposed to steroid very long, it transits into actually primary open-angle glaucoma. So you cannot be always sure, depending on how much steroid he has used, and the steroid has been given, but for plas planitis, he may have used topical steroids also earlier before the injection was given. So you can't be sure. It can continue also, the pressure can remain high. So we have to be very sure that if it does not come down, you will have to do a trabeculectomy.
Thank you. Thank you, Manish, very much. Now I will request Dr. Jain Khatib to present his case of refraction. Jain.
Thank you for this opportunity. Can I have my presentation?
My pulsar.
Okay, so this is actually an interesting case. So this was a 45-year-old female who had slow progressive decrease of vision in the right eye since many years. Her left eye had nil vision. She had an old RD operated 5 years back. She had a history of LASIK done about 20 years back for a number of around -16 is what she said. And she had actually come for a second opinion. She had already been advised right eye cataract surgery elsewhere, and she was posted for surgery in the coming days. So when we examined her, her vision in the right eye with her current glasses was around 6/60 with a prescription of -4.5, and she improved to around 6/18 with a -7 diopter sphere. Her cornea seemed clear. We couldn't make out any flap margins of the LASIK procedure. And her lens showed a small central nuclear sclerosis. I don't have the actual picture, but it was quite small central nuclear sclerosis. And her fundus was actually normal. She had a myopic degeneration, nothing to comment about. So my question to the panel is, what do I do? Do I go ahead with the cataract surgery or get some more investigations done?
So I think the first important thing is that you need to get a pentacam done. But this is a clear-cut case of a nuclear sclerosis where you keep on increasing the myopic correction and the patient tends to improve. You tend to get nuclear sclerosis slightly earlier in patients who have undergone for high myopia a LASIK procedure. So the only problem here would be the lens power calculation. So you should ideally look at the IOL Master 700, or you do a TrueNet K and you use the formula to get the power calculation. Apart from that, the patient will do pretty well. This is a clear cut. On the image, it is clearly showing it's nuclear sclerosis. So I don't have any confusion in getting this person again nearer to emetropia by doing a cataract surgery with a lens implant.
I think very rightly, such patient who 16 diopter myope and has undergone LASIK surgery, calculation of the IOL power is extremely difficult, challenging. Even if we use ACRS, ECRS, there is a formula, all the parameter we have to fill and correct that what is the IOL power which comes, which should be implanted. There will be gross difference in just simple IOL power calculation and by doing it ECRS. You have to feel that. That is one. Second thing is we have to determine also that what is the outcome. For that, macular OCT is very, very important. Whether macula is saved, sometime there may be a lot of degeneration, but macula is saved. So macular OCT in such patient, or almost we do in every case, macular OCT. So I think these two things should be done. Besides, I think already Dr. Saab has already said.
In the high myopia, the patient has been, LASIK has been done, and the cataract is there. We remove the clear lens for removal, reducing the number. As there is a cataract, I think like Mahipal sir said, we should tackle it. Only thing is that, like Jagadram sir said, that the posterior pole, that is a macula, is very important, because in such number there may be some myopic degeneration like that, and accordingly you should give the guarded prognosis, and you can go ahead, because the chances of RD are also going to increase after cataract surgery. Yes.
Right. So, I actually couldn't convince myself that the cataract was actually responsible for vision loss. Macular OCT was normal. And I always felt that why should I do surgery if the other eye had detachment, unless the patient really has, symptoms. But she convinced me that her vision was actually very poor. And we did a contrast sensitivity. And the contrast sensitivity actually shows that the vision was really very poor. And as Sir said, we went ahead and did a pentacam. The pentacam is very interesting. It shows acute flattening in the central 3 millimeter. It's going to as low as 30, and the pachymetry is not so bad. It's around 512 in the thinnest, and only in the central part. So I assumed that this is olden time LASIK, where a very small optic zone was used with less tissue ablation. And if we just study the sagittal curvature in the center, we see centrally the curvature has become as low as 28 diopter. And if we run an aberration on this, it's a very high spherical aberration. So almost 1.42 microns spherical aberration, and up to 0.6 beyond is considered really bad. And these are some of the other corneal parameters showing poor point spread function and modulation transfer function. So I concluded that it was the highly aberrated cornea along with the lenticular changes and amblyopia which led to the poor quality of vision. And in this case, I didn't want to only tackle one of them. Amblyopia, of course, can't be treated, but I thought that I want to do a corneal surgery to improve the surface of the cornea along with the cataract surgery, and then go ahead. So I decided that I'll do both. Now the point was whether I'll do a corneal surgery first or whether I'll do cataract surgery first. So if I would do cataract surgery, remove the cataract, and then go to tackle the cornea, maybe the patient would have been happy only after cataract. But if the patient would be unhappy, if I would do a corneal procedure later, it can lead to a very high refractive error because of the corneal flattening. So I thought first I'll do corneal procedure. I'll make the cornea better. I'll increase the optic zone, remove the aberrations by either LASIK or PRK, and then go ahead with cataract surgery. And I would do calculate the IOL power by using the Barrett Universal 2 ASCRS and ray tracing and all those points. So I even got an OCT done. So I couldn't make out a flap as such, and the epithelium was quite regular. So I decided to do a trans PRK with higher order ablation. And in this case, this is the profile. You can see it's a zone enlargement profile, so it would lead to a central, bump in the cornea. Post-operative day 7, the patient was around -18 because she had become more myopic because of the peripheral ablation, and this would come down. So post-op day 21, she was -16. Post-op day 40, she was -14. The epithelium and corneal surface had stabilized, and you can see the difference between pre-op and post-op pachymetry, how the zone has got enlarged quite well. And this is the change in pachymetry, which is quite similar to the ablation pattern that we had planned. And if you just see the front surface of the cornea, from that 28 diopter, we've made it to around 41, 42, which is a more physiological cornea. And if you look at the spherical aberration profile, it has come down very significantly. Even the total higher order aberration has come down significantly, and so has the modulation transfer function and point spread function. So here we repaired the cornea first, and then we decided to go ahead with cataract surgery. Cataract surgery, we decided to put a 3-piece spherical IOL so that it would be a good amount of spherical aberration. And in the IOL power calculation with a Barrett True-K, we got plus 4.5 diopter. We also did ray tracing, which came to around 1.5 diopter. As far as toric lens, we decided not to do toric because we were anyways doing a 3-piece lens and there was not much astigmatism. Final power which we took was around 3, which was an average of most of the formulae. Post-operative 1 month, she's uncorrected 6/12, best corrected 6/9 partial, probably because of amblyopic and myopic degeneration. She's happy with wearing only reading glasses, and her contrast sensitivity also has considerably improved. Now, I don't know whether I did right by doing this and then cataract, maybe only cataract would have helped, but I just realized that I always feel cataract may not be the answer to everything. I always assess the subjective visual quality by contrast sensitivity, and a stepwise calculative approach is needed for complicated cases.
So anyway, I think you got away with good results. See, the patient had a LASIK several years ago, right?
Yes.
And the patient was reasonably happy, and there is a definitive history. So the abrasion profile has obviously not changed between when the LASIK was done and now. I don't remember you having told, or maybe I was inattentive. I don't know how many years have passed between LASIK and
20
years. So the patient was happy for 15, 17 years at least, right? So I have never had a patient coming back and being unhappy with just a cataract surgery, because the nuclear sclerosis is very clearly visible in the this picture that you showed. And you could, whatever you want to do about higher order abrasions, etc., etc., if the patient is unhappy, I would do that. And you would also get a chance to also have any refractive surprise taken. I don't know which formula you use, because it doesn't then remain a post-LASIK cornea.
Right.
So a post-LASIK cornea has specific formulas which give you good outcome. You were lucky to get, because you have changed the topography significantly, right?
Right. So I used the Barrett True-K, which is post-LASIK.
Yeah,
and
so
ray tracing.
post-LASIK is there, but then I haven't really, there must not be too many cases with a higher order abrasion correction and doing a lens power calculation. So this thing would be simple, clear cut, and also what Dr. Jagatram and Dr. Lahane said, yes, obviously, since the history of retinal detachment and indirect ophthalmoscopy pre and post surgery would be something to not get the patient onto that. But these patients do very well just with a simple cataract. That's what I would have done. But you got a good result, so that's fine. I would do a stepwise thing myself.
Thank you very much. Thank you, sir. And now I will call upon for the retina, Dr. Harshit Vaidya. He will present the retina case. Manga sir, it is for you. Harshit. Last.
Actually, I'm filling in shoes for Dr. Ashish actually. So he was supposed to be there, but he couldn't drop, so he couldn't come on time. So I'm just filling in for him. So we do have a lot of cataract and retina cases which land up, getting crossed to each other, and it's always a tussle. Are we going to be doing a retina surgery first or the cataract surgery first? So my case is not as complicated as Dr. Zain's. It's a very simple, straightforward case in which, general ophthalmologists land up having confusion as to what should be the next step. So that's what I'll be discussing. Just a few very, very day-to-day, simple, routine cases. Basically, a 62-year-old lady came for a second opinion. She was told that she has cataract in both her eyes. The right eye had a vision of counting finger.
क्या हो रहा है?
पता नहीं कहाँ से क्या करें.
Do you need an adapter? No, so you need an adapter?
Adapter I am also having. You want adapter? आपको क्या adapter चाहिए?
अपने वाले में डाल दो यार, इनका ऑफिशियल वाले में डाल दो.
अडाप्टर है मेरे पास.
कर लो.
देखो अभी उसको करके दो.
Solution should be there ना some. अब आ जाएगा.
हाँ उधर ले आ.
वहाँ से चलेगा वो उधर से.
आ गया. अच्छा क्या?
इनॉग्रेशन यही है.
इनॉग्रेशन कल है ना?
आज भी है कुछ.
इनॉग्रेशन कब है?
पता नहीं, आज भी इलेक्शन.
आज है
1:30.
किती वाजता?
आपका आईसी कहाँ था सर?
आईसी मेरा हाल ये 1 में था.
वो किधर था?
चौथे माले.
To the case.
आज इनॉग्रेशन है.
So, like I said, she was referred to us. She came for a second opinion. Basically, she was a 62-year-old female. She was a diabetic for 25 years. She was on oral hypoglycemics, and she was also hypertensive. She had nuclear sclerosis grade 1 and 2, and the fundus picture was something like this. We can say roughly that this was more of a case of a severe NPDR. I'm sure all of us, regardless of what specialty, but we do the next step, which will be the OCT. The OCT showed in the right eye, it had an ERM along with diabetic macular edema, along with SRF, and the left eye as well had cystoid spaces, SRF, along with thickening. The vision in the right eye was counting fingers 2 meters, and the left eye was 636 parts. Now, it's a basic question, sir. Manangat sir, what should be the next step for all of us in this situation? Because the patient has come to us for a cataract. The patient was actually counseled for a multifocal IOL, which is often the case which, retina specialists land up getting, that you have a multifocal IOL and you have to convince this patient. So what should be the takeaway here, sir?
Well, the first question is no multifocal IOL. You have to very thoroughly convince the patient that multifocal IOL is going to be totally out for a situation like this, whatever it may be, because their outcome is going to be so poor otherwise that it's going to be a problem later on. So that is out. But the question here is that it looks like that it's not only having a issue in the eye, maybe systematically also there's a lot of issues, because we see a subretinal fluid also in both eyes, and massive edema, and the type of retinopathy, the retina with the way it's seen. I would like first to also have a systemic evaluation where you do all the tests, not only that you're going to do blood sugars, lipid profile, also 24-hour urine protein, as well as also looking at HbA1c. All those parameters are very important, because
So
why it is important
So the
is
urine protein is something that I had heard you say last time as well. well, because that's something which we don't do it in regular
That is why
practice.
we've been emphasizing from our center that very much. The problem is we always do blood urea serum creatinine, which takes so long. When the kidney is damaged, it is a parenchymal damage, then those parameters would rise. It's the initial would only be microalbuminuria, and it will come best with the 24 hours urine protein. If you do that, you'll get how much protein is coming, and there are good medicine these days that you can at least, if not improve, but further it can be sort of halted, or slower progression would be there, because that will also contribute to this as well as patients' other morbidity. So doing just blood urea and serum creatinine is not at all in the beginning. That will always be normal and give a false hope to the patient as well as to the doctor. So this is my request to all the cataract surgeons, at least get 24-hour urine protein. That is what is required, and no multifocal IOL here. And of course, once we have done that, then the way we go here is definitely we would like to evaluate, is this area ischemic? You can do OCTA, you can do otherwise angiography, but OCTA these days most of the time reveal all. And first line therapy, even if there is these days ERM, we do try anti-VEGFs. So that is the way we go. But in case the cataract is now much more, and cataract is significant, then what we have been doing, and together with Professor Jagatram here, then we would like to use Ozurdex in a situation like this, and get everything down, and 3 months as well as you will get a good outcome. But use a monofocal IOL.
Correct. Sir, so another question would be, which eye would you operate? Because the patient complains that the right eye has been bad for a while. She came because the drop in vision was in the left eye.
That's what I'm saying, that the left eye would be more concentration. Correct. It appears that the right eye may be going on for quite some time. Correct. Things. The way the left eye appears, it is something which has happened now. It could be because of the systemic issues as well as the other issues. That's why those tests are important. And secondly, we would like to give here, if the cataract is not that significant, then we would like first to treat with anti-VEGFs. Okay. And so once it becomes flat, and then we decide accordingly. If it is totally flat, then the situation is different. But otherwise, most of the time, we try to give Ozurdex and do cataract.
Because, sir, our cataract colleagues are very eager to be operating, So that's the key takeaway,
that,
even if
you
have
they
to ensure
want to,
that the edema kind of
even
settles.
if they are eager, then use Ozurdex. That is what I would advise. Use Ozurdex, because here, if you just give one injection, it's not going to be enough. And by the time, the normal time after cataract surgery, for the whole thing to come back and super add on to this is usually after 6 weeks. It is from 2 to 3 months when it comes back, and that is not covered by your injection. So that is what happens. Yes. Correct. So give Ozurdex.
Okay. So I'll just one last case. This would be a case of a 56-year-old male who was a diabetic for 6 months, hypertensive for 10 years, underwent cataract surgery on May of 2022. This was a presentation of the OCT about 3 months later. What should be the next steps, sir? Because this is an OCT that we'll end up seeing post-cataract surgery in a diabetic patient, and sometimes we can take different decisions. People are too eager to be either injecting or observing. So, what should be the ideal way to approach a case like this?
That's what I'm saying. Either it was already a pre-existing DME, which worsened further, and that is what we are seeing, because it was not looked in. So it's very important these days that we must rule out that. In case there is a DME, I think it's very important that we have to manage that, as I mentioned earlier. So in case it has come to this stage, so you have both the choices. Since the cataract surgery has already been done, now you could use anti-VEGFs, but then you will have to use monthly anti-VEGFs, or this is a pseudophakic eye, even if there are no issues and the IOPs and other things are normal, you could give a very easily Ozurdex in an eye like this, because that will take care.
Correct. Yes. So I would also like to highlight this point that sometimes we need to differentiate the diabetic macular edema with pseudophakic macular edema as well. And this is where the foveal cysts become more important to be seeing. It's not just the retinal thickening, it's the foveal cysts. And along with it, you need to see the fundus as well. So having a fundus, just not an OCT, because the fundus evaluation is important to see if there are any microaneurysms, any hard exudates, to differentiate it from a pseudophakic CME.
Exactly.
In which
I think even the pseudophakic CME can present just like that, the way this is. Suppose there is no retinopathy, or you don't see anything in the other eye, then I would just treat first this kind of a case with topical NSAIDs,
Yes.
as well as steroids. For 3 weeks course, we usually give 3 times a day, like mostly something like whatever we give, Predfort or Novanac or whatever we like, 3 times a day for 3 weeks. Most of the times it will start reducing by that time. And if it is reducing, you continue with that. And many cases, at least in our own practice, 70 to 80% resolve with this kind of a treatment. It's only a smaller number where you may require further intervention.
Correct. So maybe those smaller number, what would be the option? Because this was that patient who had persistent pseudophakic CME for about 4 to 5 months.
Yes.
So what would be your first line of treatment in such patients, sir?
I think this is one indication where perhaps we can even try periocular steroids, so that we do try in the pseudophakic CME cases before we go on to like injecting really intraocular injections. Okay. So that can be tried.
So I think, sir, in our case, this was managed by 2 of our colleagues. This patient who came 5th month post cataract surgery, we did go ahead and give an IVTA actually. So this is why I was wondering what would be your choice. In our case, we chose IVTA. Although it was more invasive, according to you, we could have probably tried PST, like a posterior subtenance, but this is what we chose. So just to highlight this point, sir, I thought that 2 different patients of diabetic macular edema and pseudophakic CME, the incidence is still less, but it peaks, like you said, about 4 to 6 weeks. And in diabetic patient, it has 4-fold the risk. And the incidence is higher if there is pre-existing DR and previous DME. So I'll just conclude with just a few takeaways, sir, that we should actually dilate all cataract patients, ensure that we take an HbA1c, and to what sir added, a 24-hour urine protein, a pre-op OCT for patients who we suspect to have CSME or DME, or when vision doesn't correlate with the cataract grade, differentiate pseudophakic CME and progression or worsening of DME, so that the agents that we choose can be varied, like a topical NSAID or IVTA. And when in doubt, obviously take a second opinion from a retina colleague. That would be it, sir. Thank you so much.
Thank you. Thank you, sir. My question is that whenever you can do this type of macular edema, here there are so many anti-VEGF injections are there. So some are costly, some are not costly, and then they are giving this injection maybe 5, 6, 7, 8, 9. So how to reduce the number of the intravitreal injection?
I think once we talk of DME as such and we want to reduce the injection, what is happening in our country, at least we have been emphasizing of late, we don't treat these patients aggressively and early. And we are happy. We have given one injection, it became flat, then we wait for the period once it comes back and give another injection. I think biggest mistake. That way we are with injections all our life and their life. It never gets. So I think early aggressive treatment, definitely 3 injections. Otherwise, in some cases, if it is going down, give 6 injections. You can give something like a biosimilar, Razumab, cheap. Give up to 6 injections. You will find, I have now several cases, especially after the biosimilars were introduced, where they are free of injection for next 4 to 6 months. Their requirement for subsequent injection is just 1 to 2 injections in a year in a diabetic. But if we are treating it just like and then going again, then they are never free and their vision is never also good. So this is very important. Early aggressive treatment is the key.
Early aggressive treatment. Yes. I think very true. We must go for the early aggressive treatment, and so that in after that the treatment is I think not require much. So thank you very much, Mangal sir, Rashmi Gandhi sir, the Parikshit sir, Jagat Ram sir, then Manish, Agini and Maipal sir, and all the presenters who presented very well. Thank you very much, delegates who found out this hall, which is very difficult to come. Still you have came. So thank you very much. Thank you. Thank you.